Good evening, everyone. My name is Ruth, and it gives me great pleasure tonight to introduce the Solventum and Legs Matter webinar. I would love to welcome you to this webinar where we're going to discuss the missing link in lower limb wound care. Please, during the presentation, if you've got any burning questions, either use the chat function or the Q&A function, and we'll make sure that we've got plenty of time at the end that Leanne and I can answer some of those questions for you. So that brings us on to our guest speaker tonight. Our guest speaker is Dr. Leanne Atkin, who I'm sure many of you know already. I've known Leanne for many years now. We come from the same clinical background, and although our careers in the last few years have taken different pathways, we continue to work closely together. And I would like to think, and I hope you agree with me, Leanne, that we share the same values in that the priority will always be the patient and we'll always strive to improve their outcomes. Before I introduce Leanne and leave her to take you through this presentation, I would like to take one opportunity to not only welcome you, Leanne, to this webinar, but to congratulate you. And I think everyone in the audience should congratulate you also on your latest achievement in becoming an associate professor. So I'm going to hand over now to the associate professor. Thank you.
Ruth, thank you for that. Still got major imposter syndrome when you give me that title. And yes, I've known Ruth for many, many years, and I still view her as an extremely valued colleague and clinician. As many as you know, I work as a vascular nurse consultant within Mid-York's NHS Trust, and I'm still very clinically active, running leg ulcer clinics, hot foot clinics, diabetic foot clinics, 3 days a week. I'm also the very proud active member of the Legs Matters campaign, and therefore it's my delight to be here today representing Legs Matter and to be able to provide this webinar to you from one of our very valued partners, which is Solventum. And today's session is all about this peri-wound management, because I truly believe that this is the missing link in lower limb wound care. The slides that I'm going to present to you tonight are all of my mind and my experience, and Solventum's had very little input to any of these, if not none of these. I would really welcome any questions, any comments, any of your experiences throughout all of this. So please add them to the text in terms of the chat or the Q&A function if you want to ask a specific question. I really like it when you lot get involved with this, because sometimes speaking to a computer can feel quite alien. And so I love it when you tell me who you are and where you're from, such as Claire Skinner, who's just told me that she's out in Kent in England. I'm watching that little chat button, and so please get involved, make this session as active as possible. So why am I talking about the peri-wound skin as the missing wound, the missing link if you type of lower limb wound care? It's because actually a lot of the education that we give is focused on the wound itself. But actually, when you start to look at the peri-wound areas of all of these types of wounds, it's actually the peri-wound area that we need to start to concentrate on, because unless we're actually managing that underlying cause, that underlying inflammation, that moisture management, that hydration of that skin, we're never going to be able to get these wounds to actively epithelialize and to actively heal. So we're going to concentrate very much on all of this tonight. But it sort of leads me to a question of really, how does the damage occur? How can we prevent this? And if the damage has occurred already, how can we treat that skin vulnerability? And to start with, as a clinical academic, I always like to really take it back to basics and really think about the anatomy and physiology that we're talking about. When we think about wounded skin, you'll have seen this diagram 100 times before, but your eyes will always be drawn to the void, the area of wound. But actually, in today's session, I want to concentrate on the bits of the side. And most importantly, I want to concentrate on that final layer of the skin, the epidermis. And this epidermis is actually a really important layer of the skin. It's the thinnest layer, but it's responsible from the protection from the outer world. And it provides that unique hydration, it produces new skin cells, and it acts as a protective barrier against allergens and bacteria, and it also provides the colour of our skin. Within this very special epidermis layer, there are a number of very important cells, and you'll have heard of lots of these cells. But actually, I just want to remind you that the cells are produced right down on that basal layer, the basal layer that's attached to the dermis. That's where the cells are formed. And over time, they change their shape and they become anuclear. The active nuclei of the cell starts to die away. And as they start to die away, they start to become inactive, and therefore eventually they start to shed when they get to the outer layer of the skin. But this constant transition of these cells across these planes is continuous in nature. So there are many reasons why we start to think about why, though, that this epidermis can start to erode. And it can start to break down for many things. I'm not a tissue viability nurse, never have been one. I'm a vascular nurse, but I still know the importance of how epidermis breaks down from friction, shear, direct pressure. But we also know that the epidermis can break down because of autoimmune conditions, because of allergens, and because of infection. But today's session is going to concentrate on those bottom two things. I'm going to talk about how the epidermis breaks down because of chronic inflammation and also because of moisture. When we start to think about this peri-wound skin, though, we know that it can, if we don't get this right, it can start to disrupt that ability for wounds to heal. And it can start to disrupt that by many mechanisms. We know if we don't optimize that peri-wound skin, we start to get maceration, excoriation, dehydration of those cells. We can end up with eczema and dermatitis, like you can see in that picture on the medial aspect of that limb. You can end up with trauma where you have skin stripping, infection, allergic reactions, and also blistering. And we know that all of these can start to adversely impact on that patient's ability to heal. It's adding another complexity. Not only are you asking the body to heal the wound, but you're asking that body to also deal with this surrounding inflammation that's going on. So let me just recap. Okay, so this is what we're going to be talking about tonight. It's this peri-wound breakdown. It's that maceration. It's that venous eczema. It's that surrounding excoriation. And I think we really need to pay heedance to some of that. And actually, I wanted you to focus on that skin. And more importantly, I wanted you to focus on that epidermal layer. And I really wanted you to start thinking about how that thinnest layer, that outer layer of the epidermis, is our protection from the outer world. And then on top of that, I asked you really to think about how the cells are produced at the basal corneum and how they mature, decellularize as they go up to the stratum cornea on the outer aspect. We then went on to talk about why the epidermis starts to break down. And we got to saying that we were going to focus on this chronic inflammation and actual moisture. And we then went on to talk to say that actually we need to be thinking about how do we manage these associated skin conditions, because the body doesn't just have to heal, but it also has to contend with that inflammation, that maceration, that dehydration, that chronic infection, that chronic inflammation. And all of that starts to impact adversely the body's ability to heal. So that brings us back to where we should be. We know, though, if you think about that wound healing, and we talk about wound healing in those 4 stages: hemostasis, inflammation, proliferation, and remodeling. And we know actually the peri-wound edge is important to all of that. The first thing to remember is that if your patient's having pain, it's coming from the noroceptions within the outer side of that wound. It's from that peri-wound edge. It's those that are releasing the chemical mediators that cause the pain. On top of that, we know that actually it's that surrounding wound edge, that peri-wound area, that's important in hemostasis. That's where the severed blood vessels live. That's where we need this chemical release of thrombonases in terms of being able to allow that chronic inflammation, that vasoconstriction response, that ability to clot. We also know within that inflammatory edge is where we find all of the active cells that we need. We know that that's where we find all the keratinocytes. It's where we find all the MMPs. It's where we find all of those activated cells. All those neutrophils and macrophages, those Pac-Men of white blood cells are sat in that peri-wound edge, ready to actually help to remove any toxins, any bacteria within that wound bed. But the peri-wound edge is also key in terms of that proliferation. Every wound starts to heal by actually activation and migration across that wound edge. Firstly, with a wound matrix, and secondly, with the associated cells that's required. It's where the new blood vessels are formed through that process of regeneration by the activation of VEGF to be able to actually think about how we grow those new blood vessels and how they end up end to end in terms of restoring that venous and arterial supply within the wound itself. It's within that proliferation and that wound edge where we get those fibroblasts to start to migrate, where the epithelial cells start to actually advance, and where we get that complete wound healing. But it's also that peri-wound edge that starts to shrink towards and plays a really important part with that remodeling. We often think of remodeling that happens once healing has finished, but remember, as that wound is closing, the wounds that's healed around it, that peri-wound edge is starting remodeling as that wound continues to heal. So that peri-wound edge is where all the magic happens, if you like. It's where all the healing is. It's the ability to heal. All of the magic is sat within that surrounding skin. So we've got to protect that really well. Because if we're not protecting it, we're going to stall down wound healing, and more likely, we're going to increase that patient's pain. So you can get quite often associated skin damage. So we call it maceration in wound world, but it's really interesting that actually within a pressure ulcer tissue viability world, you might also refer to this as MASD, moisture-associated skin damage. The terminology is not wrong, if you like, because actually MASD can be formed because of that chronic inflammation and that erosion of the surrounding skin. And it is caused by prolonged exposure to some form of moisture, which can be urine, mucus, sweat, but it also can be wound exudate. And what happens in this MASD is that you get this chronic inflammation, this erosion of that tissue because of that prolonged exposure. But it's not just the moisture that's actually associated with that erosion of that epithelial edge. We also think in forms of an MASD is that it increases the vulnerability of friction, where the cells can't cope with the amount of stresses and strains and therefore more likely to break down and the cells die. We also know that there can be a lot of chemical factors that cause irritants and therefore activates that chronic and acute inflammatory phase of that surrounding skin. And there can be an increased amount of microorganisms, and some of those can have a negative impact towards wound healing. But I often think that within wounds, that when we start to think about highly exuding wounds or even exuding wounds, we often think that exudate is bad. And I think we just have to remember that exudate is really good. And exudate is a vital component, actually, of wounds healing through secondary intention. Because it allows that optimum environment. And we talk about the optimum environment not just from a temperature point of view and a moisture point of view, but it's also an optimum environment in terms of it aids autolytic debridement. It increases the rate of epithelialization because those epithelial tissues only like to skate. So they like to skate on top of a moist wound. The exudate and the enzymes that's within the enzymes can increase cell proliferation, cell duplication, And the exudate contains those vital proteins, MMPs and cytokines needed. It's like bringing everything that's required, your building blocks of wound healing, through this exudate. And all of that aids cell migration, it aids cell metabolism, and it enables the diffusion of those immune and growth factors from that surrounding tissue into that actual wound cellular matrix. So exudate is good. The problem is a lot of wounds, especially lower limb wounds where I mostly practice, is if the wound becomes non-healing, you can end up having excessive amounts of exudate, where actually what you get is a reduction of the anti-inflammatory cytokines and an increase in the pro-inflammatory cytokines. So we get in this constant state of inflammation. And when we get in this constant state of inflammation, it starts to slow down cell growth and cell duplication. It starts to interfere with the activation of those growth factors. And all of this can lead that wound into that chronic inflammatory state where actually we get stuck in this cycle and not allowing the next stage of wound healing to come, because we're in this cycle of pro-inflammatory cytokines feeding a positive response of high volumes of exudate, and we go round and round. And for me and you, it ends up looking like this. Now, I put the term wet legs in speech marks at the bottom because I hate the phrase wet legs. Wet legs don't spring a leak for any apparent reason. There's an underlying cause. And actually, just calling this a wet leg doesn't do it overly justice. This is a highly exuding leg ulcer caused by venous hypertension. This is a wet venous leg ulcer, if you want to call it anything. And actually, we need to be thinking about how do we manage these patients, because we shouldn't be managing these patients simply by mopping them up. You'll be mopping up that type of wound, that type of leg on that patient forever. We need to be thinking about how do you manage that underlying cause? How do you break down that cycle of inflammation? And you do that in a patient with a venous leg ulcer with strong compression. And when I say strong compression, it's a compression of at least 40 milligrams mercury pressure. That's the sweet spot. That's where we need to be able to combat that chronic inflammation. And we have loads of evidence these days that actually compression therapy is a really good, potent anti-inflammatory device that starts to actually rewind everything that I've said previously. But within the UK, we do have a bit of a problem. And I thank Accelerate CIC for these slides. Because actually, we know the number of patients in strong compression, the use of strong compression in the UK has reduced. We have an increase in light, reduced and modified compression. But at the same time, when you look at it, the spend on super absorbers have increased across the UK. Because we are at the moment, if you're using reduced light compression, you're putting on a sub-therapeutic dose. We're not tackling that underlying cause, and therefore we're finding it difficult to get on top of the exudate. If you have patients with highly exuding leg ulcers, they're often saying, I want more compression. So with patients like this, we need to be thinking about that underlying cause. We always need to be thinking about optimizing, reducing that edema, that congestion in our leg, that controlling that venous hypertension. But I want you to start to think about not just the wound, but how do we start to protect that surrounding skin? Because actually, if we don't start to tackle that maceration, we're just going to increase that inflammatory response. And because patients often have large areas of ulceration that often can be highly exuding, we do need to think about what is the right dressing choice, and are we using the most appropriate dressings in terms of their absorbency. We also need to think about, have we got the right amount of dressing change? No patients should be left in a saturated bandage. We need to be thinking about changing the dressing regime or increasing the frequency of those patients. But actually, when you start to look at patients like this, there is a certain lack of effective skin barrier products. The problem is with wounds on the lower leg is that they're often highly exuding because of this heightened inflammatory response that's associated with that high venous pressure within that capillary bed that's starting to pump out those blood products from that capillary bed into that interstitial tissue. We're forcing the plasma into that surrounding capillary bed. Those lymphatic systems that you can see, the green within that slide, we overload the lymphatics. We're not allowing those lymphatics to be able to remove the amount of exudate, the amount of plasma that's required. Therefore, we end up with edema and highly exuding leg ulcers. We also, as part of that inflammatory response, we have an arterial dilation. We have an increased amount of perfusion actually at the base of these capillaries. That only leads to increasing amounts of movement of plasma into that surrounding space. And as that all starts, we get this breakdown of this epithelium, this large surface area, and we often have this more viscous type of exudate because of that chronic inflammatory response. And we find epithelial damage in many patients. So these are all patients with underlying venous hypertension. You can see the actual signs of venous disease on a lot of these patients. You can see the edema, you can see the skin staining, you can see the chronic inflammation. But I don't want you to look at the wounds themselves. I want you to look at that surrounding skin and start to really think about what it must be like to live with a wound that's constantly exuding. How painful must it be when that really, that quite acidic fluid starts to pour out of that wound bed. It runs down the epithelial tissue. It provides that burning sensation to your patients. You can see the amount of maceration that's happening on all of these. We're just extending that wound size. And for patients with venous hypertension, we need that evidence-based practice. It needs to be a full holistic assessment, including arterial assessment within 14 days. If it's appropriate, if it's diagnosed as a venous ulcer, we need strong compression of at least 40 milligrams of mercury, along with the consideration of venous hypertension, venous intervention. And then we need to be thinking about how do we optimize that wound in terms of tissue, infection, moisture, wound edges, and surrounding skin. But we get epithelial damage in many other cases too. This is epithelial damage secondary to cellulitis. And you can see if you're not going to start to protect the epithelium, you're just going to end up eroding more and more of that tissue, extending that wound size. You quite often get epithelial damage in patients with mixed disease ulceration, patients with combined arterial and venous insufficiency, because these patients can be tricky to get into the right amount of compression, the optimum compression to support that venous hypertension and reduce that chronic inflammation, versus how much pressure can I safely put on that leg to not impact the arterial perfusion. And these can be tricky to manage, and we often find highly exuding wounds on the lower leg. But we often can see epithelial damage in arterial patients too. But actually, the impact of this is significant. The impact of this is actually, once you start to get an increased epithelial damage, you are going to actually elongate your time to healing, and you are going to start to worsen your outcomes. You do increase that risk of infection for that individual patient. The impact to you as your service is massive in terms of increased costs and increased time. But it really starts to impact on that patient's quality of life. It starts to actually increase the risk of patient harm and patient suffering. So what can we do for all of this? Number one is we can think about prevention. I urge you all to have a read of the evidence that's behind those brilliant emollients. Skin cleansing and the application of emollient is something that is in everyday practice of every patient that I see. And I want you to really think about, how do you maintain that health of that skin barrier? Because If your skin starts to become dry, we start to get cracks. Think of that epithelial layer. I like to view it as bricks and mortar. If you've got the cells, they're like little bricks. We need good mortar around it. If that skin becomes dehydrated or inflamed, we start to get cracks within that mortar. We start to allow allergens and irritants to actually fall down the cracks within those outer layer of the epithelium, down to the dermis layer, where it can start that chronic inflammatory response. By applying regular emollients, you can keep those cells really pumped up. You can keep the fatty lipids within your mortar. You can ensure that you've got this smooth, effective skin barrier. No gaps between these cells, no gaps where the irritants and the allergens can start to fall through. So the one thing when we think about how do we maintain that peri-wound health is prevent any damage. And that's by use regular medical grade emollients each and every time that you see that patient. The next thing is to think about how do we do early intervention. At the first sign that the epithelial is starting to damage, we need to ensure that we've got the most effective skin barrier products are applied. So you can see on this patient here, you've got a little bit of skin damage, not on really around the peri-wound edge. You've got a degree of maceration, but you've got it just settling down about 2 inches below the distal aspect of this wound. And that's probably because you've got the wrong dressing choice. But this is a time where you can apply as an effective skin barrier, along with address the underlying cause. That patient needs stronger compression. You can see the amount of edema and inflammation that's on the leg. You need to be thinking about what type of dressing that this patient's being used, stepping up probably to super absorbent dressings, and also potentially increasing your frequency of dressing. So as soon as you've got any form of skin damage, we need to be thinking about that early intervention with skin barrier products. But actually, it's when we've got that complete epithelial loss, we have that significant skin damage, that the time is to act now. And we need to apply a skin product on a regular basis. We desperately need to get rid of that underlying cause. We need to increase that dressing frequency. We need to be able to add that extra absorbency. If some of you work in dermatology or are old-fashioned like me, at times we can still use potassium permanganate soaks as an astringent agent to really help us to dry up some of this. But actually, this is where we need innovation in skin barrier products. Because if you had patients like this, where you can actually put your gloved hand over that and your gloved hand looks wet, you'll have all of had those patients when they sit there, you can actually see the epithelial tissue crying. It's weeping as you look at it. The traditional skin products that we have were never able to penetrate through that. They're sat on top of it. Quite often, some skin barrier products added additional moisture. That is not what we need at this moment in time. And this is where Cavalon Advanced, I think, is an absolute unique product. It's something that is within my armoury of every patient who's got significant peri-wound maceration. I'm not being paid tonight by Solventum. I am simply telling you how I find the use of Cavalon Advanced in my own specific practice. It's revolutionary. If you look at this, though, it's a very different product. It's a different product than anything else that's out there. It's got the ability to actually penetrate through that layer of that moisture. It's got specific polymer forms that's actually able to elongate and conform straight through onto the outer layer of that epidermis. And it's very revolutionary in the way that it works. It creates this acrylic barrier, so therefore nothing can start to penetrate through that skin. The evolution of wound therapies continues all around us. I love the innovations that I see, that I'm involved in at the university, that I know is coming out of the companies. But I think we've got a certain lag between the innovation that's coming out and the actual use within clinical practice. I urge you just to think about the products that you've used today and yesterday within clinical practice. How long have those been on the market? I think most of you were using products that were designed in the 1980s, 1990s. We're still thinking about that environmental wound healing. How do we actually manage the exudate, the tissue? How do we encourage debridement? And instead, we really need to be thinking about, actually, we need to be looking at these interactive dressings, this tissue engineering, the ability to do something differently. Many of you will say that there is always the cost, which is a barrier to care and a barrier to use. But actually, the dressing cost is a tiny tadpole within all of this. Actually, the biggest cost with all of this is you, the healthcare professional. So anything that we can do to optimize these patients, to heal them quicker, is the most cost-effective way to be able to manage these patients. So I think, you know, many of us try to empathize with our patients. But I just want to take for a moment just to ask you to truly emphasize. What would you feel right now if this was your leg? That actually, as you're listening to me, you have a dressing that's becoming saturated. You can feel the exudate running down your tissue. You can start to feel that burning sensation. You're aware that actually that exudate is starting to erode my skin. It's starting to make my wound bigger. And how would you feel if actually, after listening to me today, you have to get into a taxi to go to your home? How would you feel getting in that taxi knowing that you had a highly exuding wound that's starting to actually strike through? You can smell it yourself. And when the taxi driver comments to you that what's that smell, how would you feel? I think we really need to start to think about how appropriate it is and how we manage these patients. I think many of us cut a bandage off and go, ooh, that's wet. And I just want you to really stop if you use those words and actually say to yourself, I'm going to make a promise. I'm going to make a promise to say, ooh, that's wet. I'm going to tackle that with you. We're going to make a treatment plan. This is inappropriate management. We need to get this better for you. Because actually, the impact of living with a wound like this can really start to steal patients' lives. And that's where we need to be. We need to focus on those high exuding leg ulcers, not to turn a blind eye to it. We need to think about how do we get the most appropriate management for these patients. Because God forbid if you're taking off dressings that's completely saturated, that if you've got chronic pseudomonas that you can feel, that your foot is just looking like it's been in a bathtub, that you can see your wound extending and you're worried about whether you're going to lose your leg. We need to be thinking about how we optimize those patients. This advanced technology of Cavalon is very different. It provides that protective environment that aids that healing. It's really long lasting. It lasts for around 5 days and there's no need to remove it. This is a patient of mine where we started to use Cavalon Advanced. You can see that that patient has got cellulitis and we're worried about that duration of that epithelial tissue. We started to use the Cavalon Advanced along with superabsorbent dressings and along with good compression, but we were able to get that patient to heal. We had a patient with a highly exuding diabetic foot ulcer, but again, we were able to apply that Cavalon Advanced, and this is a matter within 2 weeks to allow that wound to heal. The one thing I'd say about when we're using Cavalon Advanced, I want you to remember in your mind's eye that epithelial tissue. From the base of the basal cell of that's attached to the dermis to the time it takes to mature to come at the top, it takes around 28 days. When you're using any of these products, please don't expect to see a difference within a few days. We need time for allow those cells that you're going to now protect to come through, to mature, to actually become that visible layer of the outer layer of the epidermis. And that's why Cavalon is often provided in packs of 4, where we can apply it for 5 days to allow the epithelial to restore. As soon as you're seeing that restoration of that epithelial, you don't need Cavalon Advance anymore. At that point, we need to be turning to our effective emollients to keep that skin intact and to use normal skin protectors if required. Many of these patients are really at high risk. You might be thinking about that increased cost in terms of product costs, but please look underneath, see the consequence of your actions, see the consequences of non-healing and non-action in this area. The consequence of that is massive. Many patients with highly exuding leg ulcers do end up getting infection, having admission to hospital. We can avoid a lot of that patient harm by optimizing their care. So just remember, it takes 14 to 28 days for those cells to move from that basal layer of the corneum all the way up to the stratum layer. So 14 to 28 days before you're going to see any difference. But you protect those very, very valuable cells. And over time, they will start to restore the function. They will be built again with good bricks and mortar, and they will provide that most important, effective barrier function within that final layer of the epithelium. So please don't just focus on that wound itself. We need to be focusing on that surrounding skin, as I truly think that's the missing link to wound care. There's an opportunity to reduce patient suffering, and there's an opportunity to actually optimize wound healing. All of the wound healing is in that important cellular activity between that wound bed and that peri-wound skin. So we need to protect that magic, and using the right product at the right time, along with eliminating that underlying cause, can be the key. It can be the missing link to lower limb wound care. Thank you very much for listening.
Thanks, Leanne, for that. That was brilliant as always. And I was just about to jump in around that no pictures. We thought it was just a long intro you were giving us. So we were giving you the benefit of the doubt for a few moments. But no, that was amazing. So there's a couple of questions in the chat, but there's a couple of things I'd like to ask you just to get your opinion on. You kind of showed us there that actually reduced compression or light compression is on the increase. And we know as clinicians that we need a level of therapeutic compression for it to be effective. So my question probably is why do you think that's happening?
I think it was a consequence of the decision that we made within the National Wound Care Strategy, to tell you the truth. As you all know, we decided to allow 20 milligrams of mercury at immediate and necessary care by looking at red flags. I like that. I thought it was the best thing we ever did from a National Wound Care Strategy point of view. I didn't truly see the consequence, though, of that. And I think the consequence of that is that people linger in that level of compression for too long. We need to be focusing on that 14-day of getting them into full compression. I think even if you get that 14-day assessment, there is still some fear in nurses. And this goes back to mine and your generation, Ruth, of how we used to train people. You know, we used to turn the fear dial up of compression. You know, you've got to be a qualified nurse. You've got to do an extra course. You've got to do these competencies. You've got to be signed off with this booklet. We used to make it so difficult. And it was difficult, Ruth, in mine and your day. All of those, which lay land and which do I spiral? Do I figure it out? What am I doing here? But I think that in today's world, we've got such great innovative two-layer compression products where it's really difficult to go wrong with. And therefore, we need to be starting to turn down that dial of the fear of compression. And I think it's a really great tool. You know, and there's very few patients that are truly contraindicated for strong compression. It's just about actually having the confidence sometimes. And unfortunately, strong compression is still behind a cabinet called an ABPI. And as we know, we often lose the keys of how to get into that cabinet for many reasons indeed. Yeah. So I think it's multifactorial, Ruth, of why we are where we are with that.
Yeah. It's quite disappointing though, isn't it? You know, to think, you know, we're in this modern society and we're kind of going backwards almost, you know, sometimes.
Yeah. But you know, I think majority of patients that you see, Ruth, in today's world have got some form of foam dressing on that were designed in the 1980s, along with, you know, woolen crepe or woolen double crepe if you fancy. And I think we've eroded we've eroded the time for the nurses to be able to do the job that they need to do in this space. And I urge you all to be the practitioner that you are able to look in your own eyes at the end of the night and feel proud of what you've done. And actually, that's about doing the right thing for the patient. And the right thing for the patient sometimes is actually deferring a visit, escalating it to somebody else, giving that patient the time that you need to give that full holistic assessment to get that underlying cause and optimize that.
Absolutely, absolutely. I mean, as you said, compression is probably the best form of an anti-inflammatory you'll ever get.
Yeah.
And we should be using it. So it's just staying on compression. Casey's made a comment around those patients that actually have rheumatoid. So these patients that have got arthritis in their feet, their ankles, in her care setting, she's finding it's difficult to actually apply that compression. Any tips or tricks?
Yeah, you've got a really difficult group there. Remember that any form of rheumatoid arthritis is an autoimmune disease, so you've already got a heightened inflammatory response behind it. Those patients do need compression. Sometimes they might need extra padding on those bony prominences. And think about how you can optimize that. It's really interesting. Some of them have really skinny ankles at the same time, but you've got signs of venous staining. So you just need to make sure your optimization of compression is right. Be careful of those patients if they've got any form of insensation along with it, but if not, it's just about optimizing the compression. The thing that I find is really useful is something that can act as an anti-inflammatory at the same time. High dose topical steroids can work really well on the right patient. Liaise with your rheumatology team. And IV cyclosporins can work really well too in that complex group. And there's nothing better as a vascular nurse to actually do a joint visit with these patients with your rheumatology consultant, because these can be really complex patients. And actually that multidisciplinary MDT approach is needed. But rheumatoid arthritis in isolation isn't a contraindication to anything that we've talked about today. It's just another heightened awareness of those bony prominences. And sometimes you need really good compression skills just to make sure that you're not actually exacerbating the problem.
Absolutely. And then staying on that kind of topic around that steroid therapy, Rebecca's asked, what do you think about the use of steroid cream in that peri-wound area and around atrophy blanche and that
Okay.
kind of inflammatory? Recommended
Yeah.
or not?
So I use a lot of topical steroids. You have to be warned that they are off license because most of them are not licensed to be used on open skin. You certainly need to make sure you've optimized your patient in every single way first. So we have the right diagnosis, we've got the right level of compression, I've debrided it, I've controlled my infection, I've got my moisture levels right. But if you're not finding epithelial growth at the time, sometimes steroids can help to kick that in. What's really good is steroids for surrounding skin in terms of controlling venous eczema, but steroids on macerated venous eczema is no good at all. Think of Cavalon Advance or think of some form of zinc or calamine products can work in that area too. But they can increase epithelial growth is steroids, but that's in my own practice. No evidence base with it whatsoever, no real clinical studies. And the reason why clinical studies haven't been done for topical steroids is unfortunately they're as cheap as chips, and therefore there's very little incentive of doing a good randomized controls trial. So it can be useful, but look at that edge. Is it purpley haloed? Might be giving you some indication. Is it slightly, if it's slightly steep cliff edged, think about curetting it and actually think about refashioning that wound edge. But if it's macerated, avoid your steroids, you're just going to make it wetter. And with steroids, start high, tail down, and always tail down, because if not, you'll get rebound eczema.
Yeah, we used to always say, always go up the ladder, come down the ladder, but never jump off the ladder. Was always the
Indeed, I like
terminology
that.
we used to
I
use.
like that. You can jump on the ladder, but don't jump off the
Jump off the
ladder. Jump
ladder.
down the ladder. Yeah.
Absolutely. So couple questions around compression there in the chat here. So Fiona has said, how do you get around the pain that can be caused by compression? And I'm assuming Fiona's talking about the patients complaining of increased pain when they're wearing their compression because she has patients that are cutting the bandages off.
So I think there's a couple of things. I think number one, you've got to be a good salesman in this game. And I think number two, you've got to inform the patients why. So you saw some of my pictures on there where we have active cellulitis. And we put those patients into strong compression at the same time as active cellulitis. Now, I warned that patient that it might increase their pain, but I also said it's probably going to speed up your recovery. So actually, if I asked you, Ruth, would you mind suffering a little bit today to actually get a balance within a week from now? I'll get you out of hospital quicker. I'll get your leg looking better and normal. I think there's a degree of, we often think there's too many barriers. And if you give your patient an informed choice, they often would. I often also think sometimes we put our own view on it that, oh, that will be painful. And actually the evidence is that the compression is a really good anti-inflammatory device. In other words, it's like taking ibuprofen in a way. So it's about telling your patients of the chronic inflammation that's happening related to the venous hypertension, that dressings alone are not going to help. And actually, we need to break down that cycle of chronic inflammation. And the best way to do that is compression therapy. What I would say is, if we all had these conversations early with every patient who needed compression, we've really reduced the patients that's non-compliant. Yeah. The reason why patients are non-compliant is often they've been put in poor compression, the wrong compression, and it's been the wrong combinations, and therefore they don't believe in compression anymore. But actually, if we optimize the right patients and the right dose of compression earlier on, people will think that this is amazing. My daughter-in-law is now 39 weeks pregnant. She is living in a compression hosiery because she's seen the impact as soon as she takes it off. And I think it's about finding solutions to some of these patients rather than actually saying that this is a direct barrier.
It's about changing that narrative, isn't it, around compression? It's a treatment, and patients tend to, be a bit more on board with the treatment rather than a dressing per se. Yeah. And that probably brings me on to Marigold's question. So she's saying that if a patient is complaining bitterly of pain and they're in full compression, would you reduce the compression? This patient has edema to the foot, but not the legs. How would you tackle that?
So first off, I would just make sure that the pain that they're getting is not because of arterial insufficiency. So I just go back and double check. If you are 100% sure that there's no evidence of arterial insufficiency, you do not reduce that compression, because once you've reduced it, the patient might feel a little easier, but you're just going to undo all your good work. And if anything, you're going to make life worse, and that patient's not going to go back into that stronger compression that they need. It may well be that you're in a downward cycle because you haven't tackled the compression right from the base of the toes. Using things like toe caps or toe bandaging to be able to really, or even moccasin type boot of compression to help all of that will really be beneficial. So it's about using the right type of compression at the right dose to be able to get that patient moving forward. And then don't forget, paracetamol is a really good drug. If taken 4 times a day, it gives a really good baseline of analgesia. Things like ibuprofen are also really good because of its inflammation, and all of these is inflammatory diseases. Obviously, if you're a prescriber, take a full medical history and medication history before prescribing. If you're not a prescriber, liaise with your local prescriber before recommending any form of analgesia. It can be a tricky aspect, but it's certainly the key to it is getting rid of that edema, breaking that chronic inflammatory cycle, and get that patient on that way to healing.
Absolutely. So we've got a patient healed in compression. We move then to compression hosiery, as we know. And Liz is just saying, in the chat here that actually often, or it has happened, that when you're moving from that full compression to hosiery, you're getting skin breakdown following that swap, despite the skin, although it be fragile, is healed. Any particular reason that you would think this would happen, and why, and how do we avoid it?
Liz, I'm with you. I'm feeling your pain. Please look at my article that's about to be published in Wounds UK in the November edition. I think it's because we're lowering the dose of compression, and we probably don't need to. We have a strange thing within our world that actually, if you look at the evidence base, the best evidence for prevention of recurrence is class 3 compression. Nobody offers their patient class 3 compression because we all think it's hard to get on. My flight socks are class 3 compression. I can put them in when I'm in an economy seat. And I'm a big enough girl that I haven't got that much room in that seat, and I can still get them on. So I think, number one, we just need to break down our own opinions. We need to look at the evidence. The stronger the compression, the better recurrence. And I think there's something about, do we need to be using more compression hosiery kits as maintenance rather than actually taking somebody out of a bandage system that provides 40 and putting them in a class 2 stocking, maybe the British class 2 stocking that's only providing them about 23. Maybe that reduction of that compression is too much initially, because you've got to remember that you've only just broken down that cycle of chronic inflammation. So I think it's all about personalizing the dose of compression that that individual patient needs. And the thing that we're really bad at is, you're now healed, Ruth. Here's a pair of stockings. Bye. You know, wherever would you go to a medical practitioner who's just starts you off on a therapy and they discharge you there and then with no follow-up? We need to be saying, here's your stockings. Let me ring you in 2 weeks. Let me check, can you get them on? Let me check are they the right stocking? Are they therapeutically working? If I'm showing signs of inflammation again, it's my time to think you need a stronger form of compression.
Absolutely. A couple of questions around the sort of Cavalon Advanced. A couple of the questions were, can we use it on any wound, not just lower limb wounds, and any part of the body? I know you're predominantly lower limb.
Yeah, so absolutely anywhere where you've got maceration that you can use this. You've just got to avoid around the eyes, and obviously internally it's not allowed to be used, but anything externally or on peristomal skin, you're allowed to use it with no problems whatsoever. I'm here as Legs Matter. I'm not being paid by Cavalon Advance, I promise you, but this thing has revolutionized my clinic. Before, I had nothing to protect those type of skins that I've been showing you. All I could do was think about super absorbents and think about increasing dressing changes. Yes, I used to use some of old Cavalon, but this stuff is completely different. It's like black and white of what we've got now in terms of Cavalon Advanced. It's in such a lovely little applicator. It's non-sting. Patients absolutely love it. But my best tip for you, please make sure that you allow it to dry properly. At the end of the day, Ruth can't say this, but I can because I don't know this product well enough. It's a form of tissue glue. That's how you need to view this. And actually, you've got to give it a chance to dry, because if not, your dressings will stick to it very well indeed. When I say chance to dry, it's about 30 seconds. Give it a quick waft and it dries. And it provides a real nice, like an acrylic layer on your skin. It's revolutionary. You don't need a long-term treatment of this. You probably maximum all you're going to need is 4 applications. So long as you're eliminating the moisture at the same time, you're allowing chance for that epithelial function to restore. Once you've got it restored, emollient, protect it and start moving towards that healing cascade.
Brilliant. I'm going to kind of wrap a few things up together here because there's a few kind of common themes here. So you no longer need Cavalon Advanced and you're going to step down. So what kind of emollient would you step down to?
Any form of medical grade emollient, anyone that's licensed. It's got to be a medical grade because it's got a higher fat content. So therefore, it's a really good fatty mortar, if you like, in between your bricks. So no Lancome cream or anything nice. Medical grade emollients, but from my point of view, any form of medical grade emollient.
What about patients being non-compliant around that emollient? You know, Denise is saying it's a bit of an issue in her area.
Yeah. Teach them. You know, and the reason why I'm a bit of an emollient freak is that 2 years ago, I got asked to do a talk on emollients at a conference. And I read into the science of emollients. Oh my God, it's massive. And prior to doing that session, I thought it's just a bit of cream. And actually, I were real lapsy-daisy with it. Since then, oh my God, When you start to think of your bricks and your mortar, I am emoliating left, right, and centre. And actually, since I've learned the science, I'm now applying moisturiser cream to my legs and my arms every single day. There's evidence that it reduces skin tears as well going forward. And it also, you've seen all those ladies who's got significant skin damage on, and all they've got is like blisters underneath the tissue. Well, that's because the epidermis has come off from the dermal layer. There's something about protecting that integrity through the use of emollients to be able to keep that function intact. So I don't think we tell patients this. We ask them to put some cream on the legs. We don't tell them why. We don't talk to them about pumping up your cells to actually not allow them irritants and allergens to start to get down and irritate that dermal layer. Same as we don't talk to patients about why we're putting on compression to reduce that venous hypertension. And I think if we informed our patients, I think they'd be more compliant, if you like. I think it's all to do with just understanding.
You know, everyone's kind of agreeing with you really here on the call here. So someone's also asking about what do you think so they have a patient that's on wraps actually. Sorry, I've just kind of lost that question for a second there. What advice would you give a patient who often removes their wrap compressions within 3 to 4 days of use? So obviously they're the ones that are now lying over the radiator, you know, very expensive piece of kit.
Yeah, and it doesn't matter if it's compression wrap or a compression hosiery. They only work if they're applied, if they're worn. Again, I think it's going back down to basics. What does the patient understand about that need for compression? Are they well informed? Can they tell you why they should be wearing it fundamentally? And then on top of that, it's about exploring the barriers. Why aren't you wearing it? Is it the comfort? Is it the application? Is it the heat that's associated with those? Is it the fact that it's digging in? And I think that quite often we label patients of non-compliant, especially in compression hosiery, really quickly indeed. You know, we've got to be thinking about, there's so many compression products available for us out there. We've got to be tailoring it actually to that specific patient, especially compression hosiery. If you point next time you're out with your girlfriends, ask them all where they buy the tights from. You'll all buy your tights from different shops because you like different fits, you like different feels. Why is that? It's just how you are. And actually, Ruth, if you give me a pair of your tights, I would be non-compliant with them. You'd be non-compliant with mine, because if you pulled my tights up, they'd be to the level of your neck, my darling. I like them right above my belly shelf, right near my boobies, thank you very much, so they don't move. I hate the wiggle and the jiggle in the middle of the day. So I have high-waisted tights. It's all to do with what makes that patient more comfortable and what's that patient going to wear. And we just need to embrace these conversations with patients. The industry's done so well of giving us all of these options. We just need to explore them more thoroughly with us patients.
Yeah, just I know we've only got 2 minutes left, really, so some quick fire ones, really. A patient is having Actico. I mean, again, it's up to you if you want to give your opinion on it, but every time they use it, they're developing cellulitis. Thoughts?
Yeah, it won't be cellulitis, first off. There is no connection between the use of compression therapy and the infection. It'll be mismanaged, misdiagnosed cellulitis, which is basically just chronic inflammation. And it's probably the fact that you haven't got the dose of compression right. And it doesn't matter what type of compression that you're currently using, it's just not optimized in terms of that and the amount that you need on venous hypertension. Can I just also point out one point? Somebody put in the comment that they had a man and they hated the word compression hosiery because they're for women. Completely. And you know, we have specific male garments, right? So many of the companies have produced proper men's ribbed black socks, if you like, that look like black socks. And then one of the company put those male black socks in a pink box that looked like you were buying sanitary wear in it. And you're like, does nobody think about the end user of that? And again, I think there's something about our language. Should we call them compression socks? Because is that a more appropriate language? And you know, thank you for raising that point with me, because I constantly am on an evolving journey. And I often think to myself, the language that we use sometimes just isn't inclusive. And and maybe it's because I'm a woman, I don't know, but I'm with you. I think that there needs to be a bit of an awareness campaign about how we can call these things from a male perspective. And maybe that's something that Legs Matters can look at doing in the future, of actually the language we should use when dealing with male clients, male patients, to be able to do all of that.
That's great. I mean, we could go on and we could chat all night about this, but we
We
have
can,
got
and
kind of,
me and you can chat, my darling, and that's
we
the
can
one thing.
carry on.
Yeah, and I'd just like to thank all of you for your wonderful comments and your praise. That's really kind of you. But I'd also just like to thank you for being engaged. Every single one of you is a little Legs Matters champion in my heart, and every single one of you is making a difference to those patients. You're off, I can bet you anything, 99% of you are giving up your own evening to come and listen to me. Why? Because you're a dedicated, brilliant healthcare professional. Don't let anybody take that from you. You enjoy your role and you keep bloody doing the amazing job that you are, because I truly believe together we can reshape care. And I think it's fantastic to be partnered with somebody just like Ruth, who has been on this journey with me for many, many years now. And it's great that we can have all this passion from our amazing followers.
Thank you so much, Leanne. And I think all I need to say is good night, Prof.